views, information, or opinions expressed during AAOA broadcast series are solely those of the individuals involved and do not necessarily represent those of the American Academy of Otoleric Allergy, its employees, or members. The AAOA is not responsible and does not verify for accuracy any of the information contained in and assumes no liability for any activities in connection with these broadcasts. The primary purpose of this broadcast series is to educate and inform and does not constitute medical or other professional advice or services. Advertising which is incorporated into, placed in associate with, or targeted toward the content of this product without express approval and acknowledgement of the AAOA is forbidden. These broadcasts are available for private, non-commercial use only and may not be edited or modified from their original form or reproduced for distribution.
Hi guys, my name is Doug Dawson, and tonight we're talking about restarting your practice and re-onboarding your staff following this pandemic. So this is a series of Zoomcasts that we're doing from the AAOA about different impacts that the pandemic has had on our practices. And I'm joined by a group of fellow otolaryngologists, and we are going to talk about how we've been dealing with staffing and issues of the restart. So why doesn't everybody go around and introduce themselves, any conflict of interest, where you practice, and how COVID has impacted your practice? And Jim, why don't we start with you, and we'll just go around the horn here.
Okay, so I'm Jim Connolly. I'm in private practice in the greater New Orleans area. Practice basic ENT as well as allergy and sleep medicine. And I have no conflicts of interest. And COVID-19 has turned our world upside down, like for many of y'all, and we've gone from furloughing 75% of our practice into, I think we have probably 90% of our employees back at this point.
Okay, Jack, why don't you go ahead?
I'm Jack Fornadley, Hershey, Harrisburg, Pennsylvania. No disclosures. Wouldn't mind having ownership in Zoom, but I don't. We have a 2-office practice with 6 practitioners. We closed one of the offices, shut the other one down pretty dramatically during the early stages. We are in the process of reopening, and we can get more into that. But the Hershey office is going to kind of open like the supermarkets for senior citizen audiometry for a week or two, and then by June 1st, we expect to have 2 offices back. That's where we are right now. We're in the middle of onboarding staff.
Well, my name is Ayesha, Khalid. I'm in Boston, Massachusetts. I work at Cambridge Hospital, which is one of the Harvard hospitals. It's really hospital employed, and we're in an academic center, so we are in a large facility. My conflicts of interest are that I am helping 2 early stage startups. They're non-commercial. One is in the tinnitus space called TardyMed, and the other one is also in the tinnitus space, even though I'm a rhinologist, called Apex Ventures. And I do a lot of teaching for MIT and Yale. So I guess another conflict is I work with a lot of their startups. So in my practice, we have had in Boston, just 100% shutdown of clinical practice for the 2nd month now. Within the hospital, among our staff, we've furloughed about 80% of the surgical staff, including MAs and nurses. Front desk. The only folks that really have remained have been the schedulers and some of the nurses and PAs and physicians that got redeployed to other parts of the hospital. We are anticipating an announcement that the state will open next week, but our plan is to very slowly open clinics starting June the 1st. We are actually deferring on allergy and audiology and probably just starting with basic ENT to start off with. And then my practice is a lot of general ENT with rhinology. So it'll be interesting to talk about the re-onboarding from an endoscopy point of view versus an ENT exam and in-office procedures. I think those will also have to come later. We may just start trying to do patient visits without a lot of procedures until we have the right setup.
Okay, Steve, how have things hit you?
I'm Steve Hauser. I'm in academic practice in Cleveland, Ohio. I'm at Metro Health Medical Center, which is a county hospital in Cleveland, kind of in between the 2 big gorillas, Cleveland Clinic and University Hospitals within Cleveland. We're like Switzerland in between. We have not really been hit that bad with the virus. My hospital typically has about a dozen patients admitted, several of whom are in the ICU. We've had some deaths in the ICU, but it's actually not been that hit that hard with the virus. Yet we have certainly been, very clamped down, as everyone has. Everyone's been very pleased with Governor DeWine in Ohio, feeling that he was very proactive in shutting things down and feeling that that has made people safer. And then things are starting to ramp up and open up again. So as of May 1st, I operated again for the first time. I had been taking sick days on my OR days. During clinic days, we actually had been doing phone visits for the most part. Slowly then got into seeing half live patients, half phone visits. Lately for me, it's like today I had 2 phone visits and I think I saw about 14 patients live. So we are shifting and doing a lot of more care in terms of protection, PPE, being very careful, selective about doing scoping. So it's definitely impacted us, and we're trying to ramp things back up again. And I have no conflicts of interest.
Thank you. Thank you. Okay. Anybody doing anything different as they bring back their staff, such as doing some kind of professional development, changing services? Or are we just scrambling and trying to restore functionality in the office, or anything different? And take it away, whoever wants to talk about that.
I feel like, and I forgot to mention, we've been doing a lot of the video and televisits, but we've also had this massive shift towards slit from skit. So instead of doing shots. So, we used to talk about cross-training our nurses and MAs in both serving the other surgery clinics, but then also ENT, including allergy. And we really only had we had 2 nurses that were well-trained. And now we're cross-training everyone with the expectation that slowly, we've been doing it for several weeks, but that should anyone get sick and or be out or quarantined, everyone has to be able to do all the different functions. And I think that's going to remain going forward. So if I'm doing an in-office procedure, or if allergy patients need to be mixed, and at this point we had been mailing the slit even within Boston, but we've switched to curbside pickup of your slit vials. There's a whole host of, it's amazing to see the different protocols of HIPAA, how you verify that the person getting the medication is the person who's supposed to be getting the medication at the curbside of the hospital. How the nurses and the MAs are taking, I think the MAs especially, are taking on a lot more responsibility. The other big thing that we've had to focus on is effective call triage, which as a hospital system was really quite terrible initially, like until this pandemic. And now amazingly, all of our nurses and MAs are getting really highly trained in triaging what's urgent for today, what needs to go to the ER. We can't talk to the 2 or 3 docs because they're on televisits or in the OR. And so that's been amazing, right? Just where do patients need to be? And then to your point, Steve, we haven't had any live patients yet, but when we do, I'm really relying on a lot of our staff to triage to me which ones of mine should bubble to the top, because otherwise we've got a backlog of hundreds of patients that need to be seen, plus new referrals. So I think referral management, call triage, cross-training of staff has kept our manager, like she's been working 7 days a week on this. Okay.
Anyone else doing some staff development or in terms of cross-training, things like that? I know in my practice, first of all, I'm in a multi-specialty group, 3 states. It's something that I have nothing to do with that, but the decision's been made to have nurses and MAs alternate every week. They have to take 1 day off, and they just alternate through that. And so staffing's been down. We were bringing people back, but they have been cross-trained to actually go over to the hospital and do inpatient things should they have a surge. So some training on CPR online, things like that, which is totally strange. Things have certainly taken an unusual turn. But anyone else have any comments about changing up what staff training series is and what their professional skill set is?
Yeah, we had the hospital really kind of decided everything in my location. It wasn't really my decision, but they really made a conscious effort to not furlough people. So, for example, our audiologists were all redeployed to be in the hospital screening employees as they were entering the hospital, doing a temperature check and handing out masks to everyone as they would come in. So, and they were doing crazy shift hours, all, 24/7 coverage for this. So they weren't screening patients as they would enter, but screening hospital employees. So, I mean, it was good because, for example, University Hospitals in Cleveland has furloughed a bunch of its employees and actually reduced salary on folks as well. So my hospital's really done a good job, at least, of really trying to not have to go to those lengths. But it's interesting, audiologists doing, running temperature checks, and they did a good job and met a lot of people in the hospital. It was interesting.
We haven't retrained anybody for different things. We're a total private practice. We're all on our own. It's sort of annoying, I guess, if all the information and guidance comes down from above. But in this case, we were left in a new situation with no rules. And we all sat down and essentially we furloughed nearly half the staff. We closed an office. We kept a cadre of people because our head and neck cancer business obviously had to go forward. There were post-op patients that we had to make some decision. We obviously scoped a lot less of them, but we still had to stay in touch with them, make sure they were irrigating, make sure they weren't in trouble. So we had a cadre of women who just basically put on scrubs and come into our office. We screen everybody at the front door for temperature. They have to wear a mask or they don't get in. And as we're starting back, we are bringing back the staff and we're bringing them back team leaders, people who will understand the new way, learning how to screen people, learning how to handle equipment and even clean rooms under the new order, of which we have no guidance and no real effective outcomes, but we at least have a plan. And that's what they're doing. We kept minimal audiologists because we have an otologist, and we did some ear patients that, again, needed to come in, but very few of them. One would service hearing aids, but we really kept that business minimal till like the past few weeks. And now we're just in the process of bringing them back and dealing with people who have childcare issues and folks who are frightened about COVID and would rather retire. So we're actually in the mode of who's coming back and who do we have to hire?
I would agree with that. Exactly the same way. We have a private practice, and that was kind of the way that we approached it. From the very, very beginning, we kept all of our employees. We didn't want to furlough them, but as it took forever for the PPP to come through, we had to make some decisions, and we had the cleanest clinic I can imagine that we've ever had. We weren't seeing any patients. All they were doing is cleaning. And as our patients started to become more significant, it was mostly in the telemedicine at first. And so the need for all the extra help was very, very small. And so at some point we had to make a decision as an entity, what was going to keep us our doors open, as well as what was the best for our employees. And so as the unemployment came through, they were actually doing better in some situations than they would have been if they were staying there. And so that's some of the major issues for us right now. We're still building our practice back, but as we're trying to get some of our employees back, some of them feel like it's almost better to be on unemployment. Now, part of that is our own issue. Maybe they weren't paid as well as they should have been. Part two, in our approach to it, when they went to unemployment, we made a conscious decision to keep them on our practice health insurance policy so that they didn't go bare. And so at some point, we'll have to figure out how long we can do that if they're choosing not to come back. We have redistributed them. We have a lot more people in the parking lot screening patients. One of the ways that we've tried to decrease our foot load in the office is by keeping people in the parking lot in their cars and bringing them in as we have a room available for them, so that they're not kind of being on top of each other and keeping our 6 feet distance. And so we have a new need that we did not have before. And there are definitely people in different positions, and some of the needs that we had before are no longer there.
I'll say one other thing, Doug, that we've noticed is a role which is really funny. We call it the hall monitor role or the PPE monitor role. So just, it's funny to hear like Jim, you and Jack talking about, private practice and not having any guidance. And, Steve, you're so positive about, the hospital gave us all the guidance on what we need to be doing.
Yeah.
Like our hospital tried to do that as well, but it's funny because at the end of the day, ENT, otolaryngology, is really different than a lot of the other services, because so much of what we do is in the nose and in the throat, that we would constantly have these conversations where like everybody will do this and then there's ENT and ophthalmology, and so we don't know what to do with you guys, so do nothing. So the monitor role, I think, is an important one. In fact, it's what our PA is serving as, both in the hospital and in the clinic. And it's the person that determines, like kind of does a walkthrough daily to make sure that the algorithm of screening in the parking lot, what you're wearing when you come in, are you keeping your mask on as a patient when you're sitting in the room? Like all the things that we're trying now are actually happening. Congregating, like the staff, they haven't seen each other in a while. When they get together, they all sit separately, but at lunch, everybody jams into one room. And I've been guilty of that too. Nobody wants to be sort of the bad guy or girl and say, we can't do this. So they've actually designated in each practice site, like the hall monitor, whose job is to spend a portion of their day talking to patients or employees that are not following. Because I don't know if you guys have seen this, but there's a lot of people in Boston even that are just pushing back. Like they'll put the mask on, but it'll kind of be hanging here. I call it like the fashion mask. It kind of droops down. So what do you do with that, right? In your waiting room, in the patient room, you want to have a good practice, but at the same time, you have to keep your employees safe. So that's a whole other role that is like, I think, essential for ENT compared to other specialties, especially with what we do.
Yeah. We took the nice chairs out of the waiting room and we put the vinyl exam chairs out. We have 6 of them in one office and 4 of them in another. That's all the room that allows space. Beyond that, people have to wait in the car. So you wait in the car and then we can text you and come in. That way, otherwise you're texting them and you're waiting while they come up on the elevator. So we have a very, very small waiting room. And we've already had altercations at the front desk. We had our clinical head nurse, people come in with no mask. We do not have masks to give away. We have no N95s to give away. And even the regular masks are not easily available to us. We got enough for the staff, and the patients need to come in with one or they're not. And nobody comes in with the patient. If there's some old person that just can't make it without their daughter, okay. And if it's a pediatric patient, but otherwise all the family members that come are tossed out to the waiting room. So it's really the patient only. That's kind of the minimization we've done.
So we're blessed. We have no elevator that's necessary. So we have a parking lot right in front of all of our buildings and practices. So it's much easier from that standpoint. Part 2, we repositioned one of those people into telephone calls before any visits. So everybody's given the rundown and they're explained that, look, this is not only for their health, but for the health of the employees as well as the other patients. And it's a state law rule or governance. And so we cannot jeopardize those situations. If you don't come with your mask, if you're running a fever, we're going to turn you away. You've had exposures, it's fine. We can do this by telemedicine. We're not going to shirk your therapy, not provide care to you. We're just going to provide a more optimal care. And so we try our best, but just like you alluded to, there's always those people that just want to test the boundaries. And so you just have to explain to them that this is not a good place to test those boundaries.
Okay, anybody trying to be leaner and kind of not fill out their staff to quite the extent that they had before the virus?
We were awarded one of the PPP loans. And so that changes our dynamic a little because its goal is you're supposed to hire back staff. So one of the things I guess it's a benefit is without the business yet, and actually we do have the business, but the idea is we're bringing people back faster than we would because that's the whole purpose of the loan. So it puts us into a different situation. And the good part of that is since we haven't fully opened the practice, we're getting time to run people who've been sitting home for 6 weeks into the idea of what it's like having to monitor people before they come in and the whole new cumbersome way we have of doing endoscopies.
Yeah, and there is, I don't know if anybody's taken a look at the Big Academy AAO-HNS guidance to the return to practice for otolaryngologists, head and neck surgeons, part 1, the dynamic document that talks about all the things about returning to practice. They don't really mention the things that we're talking about tonight, but if you're talking about PPE and things like that, there are a lot of good references there. I'll just call it out. So otherwise, anyone else doing anything differently? We are trying to rebuild now, and we've been granted elective surgeries this week, and Thursday I'm doing that for the first time. We've drilled down our staff, and like I said, one of them is furloughed every day, 1 day a week, and then our nurse practitioner, who was full-time, has now had 2 days a week. They're off, and now I find myself, I have just a really large number of surgeries that need to be rescheduled and prioritized, and really a staff member and audiology, scheduled like you guys are talking about. And there could be a staff person that does nothing else but that new function. And so we're looking into how we're going to grant this and open up the practice again. And does it mean that we bring the nurse practitioner back full time? Yes, but the bean counters aren't so happy about that prospect. So
yeah, I mean, I think both for Mass Eye and Ear and our hospital, there is a very complex document that each hospital has created, or each operating room. I think those are helpful for folks to have and to share. And you're right, it's a pretty lengthy situation because it borders on when and how will you test patients that are having surgery. So that's the front end. Where will you bring them in and screen them, which, we're all doing for clinic, and that makes a lot of sense. And then are they healthy enough that there's a high chance they'll go home? They won't have an issue. They won't need to be there for a longer number of hours. And then the second step to that at both the operating sites is, do we decide to do very complex surgeries on sicker people some days of the week? And then other days of the week, we try to run a lot of outpatient surgeries on patients with a very low likelihood of being COVID positive. So we have no idea, there are so many surgeries, but I will have to sit and prioritize, let's say 1 to 100, right? And so will the other 2 ENTs and then all the other surgeons, and then we'll be ranked by the operating room as to who can get in where. I should mention 2 important things around that. In Boston, Dr. Platt and I, we were joking about this, but we will be working evenings and weekends, because when you think about trying to fit the surgery in with the clean time, the turnover time for the room, and also with clinics, we will be running surgery clinics with whoever, whatever shifts we break up from 8 a.m. to 8 p.m. Monday through Saturday. And the unfortunate part will be you will see a patient and then wait a very long period of time to see the next patient. So what do you do in the meantime? Do you try to squeeze in a televisit? Do you work some evenings and 1 Saturday a month? If you want RVUs, you might work several Saturdays a month. So the hospitals are giving us possibilities of trying to open the practice, but I think we're still stuck on 2 fronts. And that's what I want to bring up to the rest of you. So all of that is for surgery, right? But there's still the post-operative, particularly for sinus surgeries, nasal surgeries, throat operations. So if you can't build a negative pressure room, what else can you do? There's actually a fair number of tools that anesthesia folks, and of course I'm married to one, so I've been trying to scour everything I can. There's a lot of remedies for in-office creation of negative suction around the patient. Like you can use a Neptune suction with the one that Sadek's been working on with a kind of an easy camping type hood. And within that, I could see myself doing in-office debridement, flexible laryngoscopy, just a whole host of procedures. And it's basically sucking the air around you into that and clearing the room a little bit quicker. What I was a little disappointed with, Doug, and I think that'll come in hopefully part 2 and 3, is that's where it'll be really helpful for otolaryngologists in terms of their practice setting, because they can't make major modifications to a clinic room. But what can you do to prevent aerosolization after all the procedures we do? And so if you do a surgery, you need a plan for the post-op visit 1 and 2. And I think that part we don't have any clear answers for yet.
Add to what you were talking about is the aerosol generating procedures versus non-aerosol generating procedures in terms of stratifying patients going to surgery. And they're actually from Boston, Brad Welling and Alan Workman have looked at the various procedures we do, and except for drilling in the nose, basically don't generate too much of an aerosol. A microdebrider, at least on a cadaver head, didn't generate much of a aerosolization, and I'm kind of reassured of that, and I don't know if that's going to allow us to do more things. But anyone else want to talk about how they've changed roles for staff? I was talking about loading up surgery, loading up procedures. Anyone else doing anything different using this to maybe add a different flavor to their practice or a type of patient to their practice? Anyone have a real thunderbolt strike that they're going to take care of all the vestibular stuff in the world or anything like that?
We have a waiting area that is decent size. So we've kind of spread out all the chairs, and there's actually numbers on each chair. And when patients come into the front desk, they're then assigned a place to sit, and our MTAs are actually then wiping down every chair in the waiting area. So the MTAs are doing this new task they haven't done before. So a little interesting step there.
I mentioned this before in one of the Zoom sessions, is that one of the ways that we kept our allergy going during some of this portion is that we had a drive-through. We had a spa and an outpatient surgery center that were both put to or closed at that component. And so we were able to utilize that to treat some of our patients that were already on immunotherapy, even though we were holding them where they were. So if they were at their maintenance dose, that they could still get their therapy in a drive-through kind of fashion, where we had a large parking lot that we had already access to, that they could park and we could wait for any clearance of their anaphylaxis, but we didn't have to do that with them being close to our providers or other patients. And that's been a big hit. And I know that we're not the only practice that has done that, because I know that there are other practices in Louisiana that have done similar things. But I do find that that brought on different skill sets for those employees. And it does look like it is something like telemedicine that the patients really are gravitating to. It's not quite sure what to do about it in the future, because I'm hoping at some point the spa will be allowed to be opened again, although that is on hold in Louisiana until at least June, if not longer. Our ambulatory surgery center is allowed to be back open, but we can't do it in our old place for our allergy clinic. It doesn't have that same accessibility. So that may be something that we have to think about long term, of how that could be potentially kept in the appropriate patients, but I don't know. They may abuse it too. As we start to get a more filled parking lot, they may want to leave a little bit faster than we would want them to. So I don't know.
That just sounds like that's impressive. I'm impressed. That's a game changer, because we just couldn't figure out a way to we weren't allowed to have patients come in for shots. And the biggest complaint, well, first of all, it's too cold. I was thinking through what you were saying. So Boston's a little bit cold, and I don't think even today, the parking lot might not have worked for people. But I will tell you that patients hate, particularly in cities or big hospitals, to come in and park and pay for parking or, walk. That's just really interesting. And the skill set of monitoring multiple people in a location and triaging that and feeling comfortable with that is really, it's really cool allergy training. So I don't know if you're going to be able to get rid of that or evolve it into something, but I will tell you many more patients will sign up for immunotherapy if we could offer any such model in Boston where you just kind of came in and went into one door, even got it, sat and left. Whereas right now it's very clunky coming into the practice still and checking in with everyone else.
Right.
We have the same reason why a lot of people don't want to do SLIT, right? Because it's so easy to come in and it's covered by their insurance. And so just like for y'all, it's easier to get them to do SLIT because it almost makes it more cost effective for them.
I think there'll be a lot of things in our practices that change as a result of this. Like, patients, some of them really decide they really like this telemedicine and they'd really rather do that than come in for a visit. And for some of the checkups and so forth, that's not unreasonable. But we have to figure out a way to effectively bill for that before that really, lawyers can bill for their phone discussions. At this point, it's still sketchy for whether or not we can actually truly bill for it. Our hospital is having us do codes and so forth, but they're still not sure, are we actually going to get paid for that?
Well, there is some relief through CMS in terms of some things that are getting paid. And there are the codes there. And Karen Zupko, proprietary stuff, but she does a great job, and it's open to anyone who wants to talk about telehealth or telemedicine and talks about all the definitions. And there's quite a resource on her website for KZA associates if you want to dig into the telemedicine type field. But talking more to staff, Jackie, you had mentioned that some of your staff or one of your staff is kind of thinking about retiring instead of coming back. Anyone else losing staff besides Jim, who talked about people not wanting to come off of unemployment? But
we've even been a little tough. We've been real generous with the staff. We've kept them on our health insurance. We sent them supermarket cards the first week or two till they got on unemployment. But we are playing it straight. When we need them back, we give them a recall letter, and they got a choice. They come back to work, or they say they can't come back to work. And we're tough. We're just, sorry, but we need our trained staff, or we need to replace them. And so we're being a little gentle if it's about childcare and they know there's a week or two, and then maybe the center will open. But otherwise, it's like, you're in or you're out. It's time, and we need you. And one lady decided to retire. A couple have unreconcilable childcare issues, and we're just going to have to replace them. But people are pretty understanding, and I think in general, most of them want to get back to work. They're kind of done helping their kids with math.
I think the other thing that brings up, though, Doug, for me, the biggest takeaway is the fear. Our staff has been thrilled that we've been video and televisiting, like by ourselves in a room or at home, or if we're seeing patients, we're seeing them in the ER. We've had a lot of employees. I think Boston hospitals, of course, are on the outlier, but I will say that, most of them are 100 plus employees. Ours is 150. The highest is like 200. And I have no numbers as to how those people do, but with HIPAA, you don't know who's sick. So there's a lot of questions around, was it any of the nurses or MAs that are in surgery, because we don't see each other anymore. Everybody's redeployed doing these different functions that Steve mentioned within the hospital. So our staff is scared. And I fundamentally feel like people will come up with reasons of why they don't want to come back to work. But the reality is they're just like the patients. They're not so interested in coming in and trying the first 2 weeks. And it's really funny to see how there's one MA and one nurse that I work really closely with who are like super diligent and super willing to start seeing patients. But the majority of them want nothing to do with ENT and are looking for other roles. So I don't know if you guys will come across that, but the fear is really real for them, especially if they know someone that's gotten sick.
In general, I mean, one of the things is we don't have to share MAs with other clinics. So our people are all
Right.
pretty loyal ENT, and we've taken them through the steps. You know, we've talked actually with the people who are working there, which is why it's nice bringing people back a little at a time, bringing the leaders, because we've all been part of the discussion. How are we going to clean the room after a scope? How are we going to do it? We've actually bought HEPA filters. We bought the 240 cubic feet per minute. We've calculated our room square footage. We figured out how long it will take to get 7 transfers of particulate matter. And we've done the math with the MAs. And, you know, does it make a difference? I have no idea. There is no data, but it seems to be the best we can offer right now. The hospital, by the way, Harrisburg Hospital, I thought I would just show everybody, bless them. This is their high-tech solution. If you can see it, they've basically knocked out a window, put a hole in, and run an exhaust fan. And it's low-tech, and it's the hospital. And we thought about that. That was a fairly expensive line item that the landlords didn't have a great idea about. So we're doing the HEPA units, sometimes 2 in 1 room. And people feel a little more comfortable about that. They see a piece of equipment. I think it helps defray some of the anxiety.
Yeah, I would agree. At the very beginning, we had a lot more fear because of the unknown. And there were probably some employees that did not want to come back because of fear, not just because of making more money on unemployment or having childcare issues or whatever the issue was. There was a lot more fear at the very beginning. We did the same thing. We brought back our leaders, the people that were the most seasoned, the people that were going to be implementing the new programs of how we were going to address the situation. And as we did that, we've educated them that we're doing the best that we possibly can. And so nobody knows what we ultimately need. I mean, is a N95 mask even helping? Are any of these things going to help? But as long as we're trying to do everything that we possibly can, and we've done the same thing with the HEPA filters, and we've bought UV lights to clean the rooms. We've done all these things, got everybody their N95. We even have N99 masks now that they can wash, and they don't have to feel like they needing to reuse these things. So I think you do the best that you possibly can, but there's no doubt that fear is there when there's an unknown. But when we articulate the unknown and that we're trying to address it to the best of our abilities, I think most of them, especially the people that have been with our practices for a while and already know what makes us tick is for healthcare, and not only for our patients, but for our employees, that for most of them, that's no longer the issue. Most of them now, it's purely an economic thing.
I would just say that we are starting back with our staff. I have a group of 7 that help us, and they are the best team I've ever worked with. And we have been really stressed out, and it is the fear of seeing these patients. And we only were down 2 weeks and then started back seeing emergent and urgent cases and bringing them in. We do the best that we can, but we're really flying by the seat of our pants too. And I think it is a real uncertain situation, and we're trying to lead the rest of the clinic in our building because I think that really ENT and otolaryngology knows best in terms of how to deal with these viruses, because we're in the area every day, so we can provide that information.
Doug, I have a question. How is everybody handling, what if I get sick? What if I need to get tested? Is it available in your areas? Because I'm curious about that. I think everything goes well, and I think you're right. If you have an answer to the unknown, such as here's our policy, if you're feeling sick, the steps you take, I think that's really important too at the other end. My
organization has laid it out for employees. They're well supported should they get sick. And that's basically, they sometimes have to use PTO if they don't have enough of sick time and things, but it is something that they're really protected. How is private practice dealing with that?
We've had staff members get sick, and the rule is, if you're running a temperature, if you have symptoms, if you've had a contact, you're out for 2 weeks without any trouble. If you're sick, we have dump them into their primary care or the hospital evaluation network because we don't have anything right in the office. And then, you know, funny, the rules aren't. Some people say 72 hours after the last fever, 72 hours after the last symptoms. We've tried to follow about an idea of about 2 weeks out if you've got it, and not coming back till you've been without symptoms and fever and stuff. And we sort of feel better the closer we get to a week rather than 72 hours. With staff members, I've taken my guidance from the infectious disease guy that's running at the hospital. I just give him a call, and he's sort of helped us guide through those.
I would say that we have the same situation once again. We're, even though we're in private practice, we are part of a network of physicians that support that hospital system. The hospital systems here, at least in the northern area of Greater New Orleans, are not as inundated as they were at first. And our turnaround time for testing is dramatically improved. I mean, literally it would take 7 to 10 days to get back a test at the very beginning of all this. But now they have the Abbott and the Roche machines, and they can get it back in 24 hours easily for an employee. And for some of the patients that are being scheduled for surgery, if they showed up and for whatever reason they could not find their results, they're able to do it in an hour. So they figured out ways around it, and they've been nice enough to keep us as the providers in the community so that we don't lose our staff in a way that really protects us, that they're not sitting around for 72 hours figuring out, hey, are they going to be positive? Do we have to put them in the CDC classification of 10 days with the 72 hours from their fever, whatever one's longer?
My hospital was very selective with who we could test initially. They didn't have enough reagents, etc. And subsequently, though, they have developed it further, have in-house testing, so we can test anybody that, you know, that we have any suspicion on. And frankly, for all of our elective surgeries, all of the patients are getting tested a day or 2 days before surgery, and we make sure that's negative before they can go on. Now, to be honest, I thought that was maybe a little bit extreme initially until I had an 8-year-old for tonsillectomy that came back positive the other day. And so, of course, was canceled. We didn't go forward with the surgery. It's interesting the things you find out. I personally had a big exposure myself and was tested 9 days after the exposure and was negative. And then the hospital offered antibody testing, which I thought for sure, well, I must have had it at some time in the winter, and this is why I didn't catch it from this woman who was coughing in my face in the office, etc. And wouldn't you know, actually, even the antibody testing was negative for me as well. So I apparently never had it. I don't know how I didn't contract it from this woman coughing in my office. It's because she came in right before we were doing all the protective gear. In any event, that's what's going on in my hospital. We are testing everybody before our elective cases.
Yeah, as are we. Why don't we go around and kind of summarize the one take home that you'd have from this experience regarding staffing, regarding re-onboarding folks, things like that, something about the office that is the take home message from this. Go ahead, whoever wants to jump in.
So for us, I think it's about just being more efficient and more conscientious of the diseases that we encounter on a day in, day out basis. Not only for our patients, but for our employees, speaking about tonight, of who you're bringing back, how serious they are about it, how important they are to our practice, and so we want them to be safe, and how they then can be a carrier and a potential harm to the patients and other employees, and trying to figure out how to do that in a cost-effective manner when we don't really know what the effects are of what we're implementing. The cost is, we just don't know what the effects are. And so I think that there are some things that that we've implemented that I think that we could all argue the costs aren't that outrageous, and we could have benefited years ago with it from other contagious viruses and entities. And so those will continue, and we'll hopefully have some more knowledge in the near future about the rest.
So I think it's been a real opportunity in the sense that we're super interdependent on each other, literally. Like, it's very funny to see that our nurses and MAs now determine who we see in person, who they feel could be a risk, who based on that pre-screening conversation they don't feel comfortable bringing in, and how much our communication around that is streamlined, how much nobody really questions each other within our small team. If Jessica, my MA, says this patient's no good, she was sick last week, she just wants to come in and she's sort of minimizing symptoms, let's get her tested first, then absolutely we're going to do that. So I think it's empowered our staff, and I think that's a big opportunity. They feel like we listen to everything they say because they're on the front lines on these phone screenings and physical screenings. And then the other takeaway for the staff too is that the technologic portion is huge. So in order for me to do a video visit, like, I first made our staff that was like, oh, the patient will figure it out. I said, well, why don't you figure it out? Let's do it together. And we all learned that how not easy it is on all the different platforms. So they've come a long way, but I also feel like it makes them feel that we really listen to them and trust them. And that, if they don't get sick, we don't get sick, and vice versa. So to your point, Jim, our bar is pretty low. Our bar is, we don't want any of the staff or employees getting COVID, because we're still inundated with it in the community. And as long as that's not happening and the days are growing, we're happy. Like, everyone's actually pretty happy with, ramping up and getting back to work.
I would say the two takeaways that I would note, adaptability. People have really had to step up and realize that these are times have changed and they really have to roll with the punches. So that's been a big learning curve, but very important. And another, frankly, is gratitude in terms of being so happy to get back into the operating room. It was so hard to not, you don't realize how much you value that, how important that is to you until it's taken away. And now having that back, you're like, oh, I don't care if this takes long to clean the room. Just, I'm here, I'm operating. It's wonderful.
I think, and this kind of dovetails a little bit with what Jim and Ayesha were saying, is including the staff in the decision-making. Our clinical head nurse has really had much more to say. She goes back and forth to the partners so that the young MA staff doesn't feel like these are the tablets being brought down from the mountain. Basically, everybody's been involved in the decision. We talked to them about how we were going to examine ears, how we were examining noses. They've been involved in finding the protective equipment. We sort of had a raffle to see who could find an N95 mask first. All these things have made our staff feel that they're part of it, and that the procedures we're using, we've all agreed on, even though there's not great data. And I think the folks coming aboard notice that. We've taken time with them. We've tried to explain to them. And the young staff, the MAs, are right there saying, yeah, this is what we're doing, and here's why. And then we back them up. Some nice little old lady comes in without a mask, pretends that she doesn't have a scarf in her closet somewhere. You need to back up the staff. You need to say, sorry, hon, you're going home for this one. We're not handing you masks. So that's what's worked for us. And so far, I think everybody's in a pretty good place.
Thank you all for taking your time tonight to talk about onboarding staff. Appreciate your time and discussion for the AAOA. I do want to just call out that there is a lot of resource out there. There are many different sources that you can get on this type of thing, from medical AMA to AAOA. AAOA is developing things like these webinars, and we do have the digital course that's going to be coming up. There's going to be more on our website about that, as well as watch your emails about some things being announced. And really appreciate everybody's time tonight. So thank you very much.
I may have missed it, but you might want to state that you have no disclosures as well. I just wanted to make sure you got that out.
I don't. I am an employed physician. I appreciate that, Jack. I do not have any conflicts or disclosures.